Yes, good morning. My name is Dr. Paul Mitei. I'm a specialist obstetrician gynecologist, and I work hand in hand with the team at the Department of Obstetrics and Gynecology, otherwise called Reproductive Health. Kisumu Specialist Hospital has got a maternity ward with 8 beds and 2 private delivery rooms, and we have a theater that has got 2 theaters. This is to ensure that if there is an emergency and there is an ongoing procedure, then you're still able to handle that emergency within the time frame that is required. At the same time, when you have 2 delivery rooms, you're able to conduct a delivery if an emergency comes and there is an ongoing delivery. Yeah, we do have about, we have 6 obstetrician gynecologists covering the hospital, and we have a number of nurses who are well trained in midwifery. Today, I would like to talk about Cesarean section. This being the Cesarean section week, it will be important just to mention a number of things about Cesarean section for our clients, so that they stand informed as they visit us. What is Cesarean section? Cesarean section, by definition, is basically an incision on the patient's abdomen and the uterus to deliver the baby. In other words, it's an alternative route for delivery other than vaginal delivery. And it is only done if there are reasons that require cesarean delivery. If vaginal delivery is not possible for certain reasons, then we do a cesarean section. Cesarean section rates have increased over time, owing to development of equipment that are able to pick problems early. So cesarean sections rate has actually gone up because of that, and also equipment that are used for intrapartum monitoring are able to pick more problems during labor. However, the World Health Organization recommends that cesarean section rate should be about 15% at the minimum, because worldwide there has been evidences that the major causes of maternal mortality and even newborn mortality is related to patients being denied cesarean section when they actually need it in labor. And that is why many patients go to get obstructed labor and get fistulas developing, what we call obstetric fistula with incontinence of stool and urine. So World Health Organization determines that 15% of the cesarean sections of rates would actually be able to forestall these problems. Cesarean section can be classified as elective, which means a planned cesarean section, and emergency cesarean section. Emergency cesarean section can be classified into 3 categories based on the urgency of cesarean section. We have category 1, where the patient requires immediate cesarean section. Within 20 minutes, the patient should be in theater. It means the life of the baby and the life of the mother is threatened, and therefore imminent delivery is important. Elective cesarean section fall under category 4 because they are not urgent. Let me mention at the outset that a number of women may actually request for cesarean section. We do not advocate for cesarean section on request, and there must be reasons for request, because we know that normal labor is much safer than cesarean section, and healing is very fast, and you will go back to your normal duties pretty fast compared to if cesarean section was done. So cesarean section on request is highly discouraged. There are various reasons why we will do a cesarean section. And these reasons are actually called indications. One commonest reason is what we call fetal distress, or what we sometimes called a non-reassuring fetal status. And this usually occurs because there is not much oxygen getting into the baby's brain for a number of reasons. And we are able to pick this through monitoring of the baby's heart rate. And sometimes it's also manifested by the baby passing stool, what we call meconium, before the baby is born, and therefore the amniotic fluid becomes colored either green or yellowish. That could be one of the reasons. The other common thing is poor progress. Poor progress is if labor is not progressing well in terms of cervical dilatation, because you're supposed to dilate from the beginning to 10 centimeters. And at 10 centimeters is when you get to what we call second stage. That is the point of delivery. So if the baby's head is not coming down in sync with the cervical dilatation, then we may say that there is poor progress in that manner. And usually we draw a graph of cervical dilatation and the descent of the baby's head. So if those two things are not going together, then there is a problem, and we make a diagnosis of poor progress. And in that case, we do a cesarean section. Bleeding during labor or before labor is one of the reasons why we do cesarean section. And the causes of bleeding can be premature separation of the placenta. We know that the placenta separates after delivery. When the baby is out, then the placenta separates. But there are instances where the placenta separates when the baby is inside, and therefore there is a cutoff between the baby's oxygenation and nutrition, which is largely from the mother, so you need to do an urgent delivery to save the baby and also to save the mother. There is what we call a placenta that has been implanted elsewhere other than where it's supposed to be. The placenta usually is implanted in the upper part of the uterus, where we call the body of the uterus. But in certain cases, we have a placenta down near the cervix or sometimes close to the vagina there. And this also blocks the baby's delivery. And when labor comes, bleeding is inevitable. And that is why we have to do a cesarean section. The other thing is the position of the baby. Sometimes the baby reaches the time of delivery when the baby has not turned. So in other words, the baby's head is up and the buttocks of the baby is down near the vagina. So in that case, normal delivery is associated with complications. The transfers lie when the baby is across, and then oblique is also reasons for cesarean section. Malposition is when the baby's head is down. The baby's head is down, the buttocks are up, but the baby's head is not well positioned in the cervix to be able to come down through the pelvis. Remember that the head is not regular, and it's not circumferential per se, but it is more ovoid. So there are certain diameters that are bigger in the baby's head, just like anybody's head. If you get a presentation, the baby presenting in the pelvis in this diameter from here up to here, that is the largest diameter, and it will not be able to come out. So that is one example of malposition. If you have twins, and the first twin is breech, for example, then normal delivery is not possible, and we do cesarean section for that. Intrauterine growth restriction, meaning the baby is not growing as per gestation. You may find that the baby is, for example, 36 weeks, the baby's weight is supposed to be about 2.5 kilos or so. But sometimes you find the baby's weight is 2 or 1.5 at that point. That is intrauterine growth restriction for many reasons. These babies cannot cope with the stress of natural labor. So then we have to undertake cesarean section to ensure that this baby is born without undergoing that stress. Certain diseases in the mother may actually be indications for cesarean section. One is poorly controlled HIV, especially if the viral load is high, then the chances of infection to the baby is also high. Genital herpes, that can lead to baby's infection, especially if the infection is acquired in the 3rd trimester. This can lead to infection of the baby. When the baby is very big, at least 4.5 kilos, we will do a cesarean section because we anticipate difficult labor and obstructed labor. But a baby that we anticipate to be less than 4.5 kilos or 4 kilos, we may do what we call trial of labor. Because what we say is that the baby is the best measure of the size of the pelvis. Because sometimes you do an assessment when we do vaginal exam and we think that the pelvis is too small. But then when it comes to labor, you find the baby being born, probably a 3 kilo baby. So the baby will make its own way, and we will be able to know if the progress is good when we draw the graph I have just talked about. If there have been previous labor-related bad outcomes, normal labor-related bad outcomes, difficult labors, if there has been vacuum delivery, if a patient has had major tears during previous delivery, or if the patient had had what we call difficulty in delivering the shoulders when the head has come out, what we call shoulder distortion. So if a patient had done that previously, then it would be prudent just to have a cesarean section, an elective cesarean section in the subsequent pregnancy. Previous cesarean section scars is a relative indication for cesarean section because if the condition that caused the previous scar is not a recurring condition, like breach, like transfers, and it's not breach in this pregnancy, then you may want to try the scar. You may want to allow this mother to deliver normally, but under strict criteria that we follow. Cord prolapse. Occasionally you find the cord coming out before the baby comes out. So the cord will be under pressure between the baby's head and the maternal pelvis, or what we call the vagina. And therefore the exchange of gases and the nutrients is not going to occur. Let me mention that elective cesarean section, the best time for elective cesarean section is at 39 weeks. And therefore, in this case, it would be important to point out that clients should not put an undue pressure on their doctor to deliver them electively earlier than that. Because what has been found out is that babies born before 39 weeks may have what we call transient respiratory distress, difficulty in breathing. So if your doctor tells you that we are going to do this elective cesarean section at 39 weeks, then it is important that you stick to that particular decision. For those cases that have to be delivered before 39 weeks, it's important that you get what we call steroids being injected through your muscles so that they can help the baby's lungs, so that the baby will be born and will be able to breathe well. However, let me mention that if there is a reason to deliver this baby before 39 weeks, to save the baby or to save the mother, it can still be done. So for theater, we have to do certain preparations. Of course, in Kisumu specialist, if you are going for elective theater, we have a package for cesarean section, and you will be asked in advance to pay some deposit. And then we ensure that there is blood, the patient will be starved, and there will be consent that has to be signed. Anesthesia is largely spinal unless there is a contraindication for that. And spinal means a drug is injected into your spine, the lower part of the spine, to be able to make the lower part from the navel downwards numb, so that the doctor will be able to do the cesarean section without pain. You will also be inserted a catheter just to ensure that the bladder is empty, because where we cut during cesarean section to enter the uterus, the bladder is just there, and if it is not empty, you can easily injure the bladder. So that is the reason why that catheter is very important. I see a number of patients, they are very averse to catheters, but it's important to have a catheter. Cesarean section procedure, we usually go through a transverse incision in the lower part and get to the uterus, the lower part of the uterus, and deliver the baby and also the placenta. Yes, after surgery, what the most important thing is pain management, because pain will prevent you from many things, and it's important that pain be managed well, because one, it will prevent you from coming out of bed, and coming out of bed will prevent you from getting clots, what we call embolism within the veins, and it's one of the major causes of death. So if we are managing pain, then the patient will be able to move around and prevent that. The other thing is, if you're able to manage pain well, then you will be able to breastfeed as soon as possible. Early mobilization is also important, and this will be enabled following pain management. You should be able to eat and drink within 6 hours of delivery, and the catheter sometimes may be removed immediately post-operative period, but if you have had a spinal, it may be removed a bit later. The other thing is breastfeeding. Breastfeeding should be initiated within 1 hour. Within 1 hour of delivery. What are the known complications of cesarean section? I'll just mention a few, because one is postpartum hemorrhage, that is bleeding after delivery, and this may be due to inability of the uterus to contract, to issues to do with the technique. So we watch out for postpartum hemorrhage as part of the postoperative care management. The other things are injuries to the bladder and bowel injury, especially if there has been previous surgeries. So if there have been previous surgeries, you may find that the bowel and the bladder is stuck to the uterus in what we call scar tissue or adhesions. Infections can also arise, especially in patients that have had prolonged obstructed labor. It is not common with elective cesarean sections. Patients who have drained amniotic fluid for a very long time before they go into theater may also get infections in the uterus, and patients may also get respiratory tract infections, especially those ones who are not ambulant. They are not out of bed as soon as possible. They may get respiratory tract infections. Embolism, I've talked about it, and this is largely due to being bedridden for some time, you're not moving, you're not active. So we encourage patients to be active, especially within the first 24 hours. To prevent this, we also give drugs that will thin the blood immediately following cesarean section. Fistulas can occur, not just because of cesarean section, but it may occur even during neglected normal labor. So to finish, let me just look at the frequently asked questions that I have had from patients during my practice. Number one is, how long is the cesarean section procedure? Cesarean section takes on average about 45 minutes to 1 hour. That is the actual procedure. It takes longer in certain cases if there are complications, and the complications might be due to anesthesia, or sometimes difficulty in delivering the baby, or arresting bleeding. But on average, it's supposed to be 45 minutes to 1 hour. How long does it take to recover? Each individual is unique in terms of recovery. Some recover early, some recover a bit slowly, but on average we take about 6 weeks to recover from the cesarean section. Which is more painful? Sometimes I'm asked, is it labor that is painful? Is it cesarean section? For cesarean section, definitely there will be more pain and difficult and long recovery period. But sometimes normal delivery may be painful, especially if you have had difficulties during, the actual delivery, what we call second stage, and then maybe you get tears and you get, sometimes you may have swellings in the lower genital tract. So the recovery period might be a bit stormy for you. So which is safer? This is another question. Definitely, vaginal delivery is much safer because anesthesia is not safe. Surgery itself is not as safe as normal delivery, because with normal delivery you will go home the following day. For cesarean section, you'll stay in the hospital for 2-3 days before you are discharged. Yes, you will not be allowed to lift heavy things for the first few weeks. Anything heavier than your baby, you're not supposed to lift. The other thing is, after cesarean section, you ensure that you have got enough pain relief even at home. You need to take things very slowly, have adequate rest, take care of your wound, ensure that your wound is dry and clean, drink plenty of water, and eat healthy. Eat well and healthy. If there is any problem, do not hesitate to ask for help. And above all, you follow the doctor's advice. The other question that people ask is, how soon can I drive? Quite often patients will just want to go back to their normal life as soon as possible. But for cesarean section is a bit different. You will not be allowed to drive for at least 4 to 6 weeks after cesarean section. And the reason is, if you get an emergency and you want to brake, the energy may be transferred to your abdomen and may affect your wound in one way or another. Sex, this is another question that is very common, and we do not recommend that you have intercourse before 6 weeks. For exercise, we do not recommend too much exercise. We do not really recommend that you go into the gym before you are ready, and we only recommend that you move around your compound, take a walk, and gradually, gauge how much your body can handle. You will not be required to cough. As much as possible, you should suppress, laughing and coughing and sneezing. Although sometimes this is impossible. If it's impossible, you can cough with a pillow on your abdomen, held on your lower abdomen, just to protect your scar. What about sleeping? Which is the best position for sleeping? The best position for sleeping is on the left side, because this allows for proper digestion and also blood flow. However, we recommend that the best position for sleeping is the most comfortable position. A number of clients also ask, when is their tummy going back? This may require, several exercises over time, and there's no hurry in doing so, because at this time you're supposed to be taking care of your baby. But we will recommend that you have a number of exercises, and at Kisumu Specialist Hospital we have a very active physiotherapy department that can help you in this particular aspect. The other question that is very common and sometimes frustrating is, when is the milk coming? This is frustrating because you will have your baby crying, you don't know what to do, the breasts are very dry. Naturally, milk will start coming from day 2 to day 6. On average, day 2 to day 3. That's when you start having milk. And if nothing comes on day 1, it should not be a big problem, because there is what we call colostrum, which is very nutritious, and if the baby continues suckling, more and more milk will come. If there is no milk at all after day 5, then we may start supplementing or using drugs to stimulate the breasts to start producing milk. The other thing is, when do I tie my tummy? Tying the tummy. Usually we recommend that you can do this when you are well healed and the wound is very dry. But you can do it earlier with modern binders. There are modern binders that you can use immediately after delivery. The other what is it called? The other frequently asked question is how do I lose weight after cesarean section? And there are many ways you will lose weight in combination. When you breastfeed regularly, it helps you to drain your calories to the baby, so you also lose weight. If you eat a healthy diet with less sugars, less calories, then you will lose weight. No alcohol is recommended at this time, because alcohol has a very high level of calories. Exercising, starting with walking, and gradually building up, will help you to lose weight. For some patients, they may not be able to lose weight immediately, and for these patients, we recommend that they accept and ensure that they go for weight reduction exercises slowly over time. Thank you very much. That was the topic for today. Thanks.